Hello, my name is Emily Lux, and this is my presentation on the article A Randomized, Double-Blind, Active Placebo-Controlled Study of Efficacy, Safety, and Durability of Repeated versus Single Subanesthetic Ketamine for Treatment-Resistant Depression. This article was done by Paulo R. Shiroma, Paul Thuris, Joseph Wells, C. Sophia Albert, Christopher Erebus, Susanna Tai, and Kevin O. Lim. And this presentation is by me. For the abstract section, the study of repeated ketamine in open label and saline control studies of treatment-resistant depression has suggested greater antidepressant response beyond a single ketamine. This specific study compared the efficacy and safety of single versus 6 repeated ketamine using midazolam as an active placebo. Subjects received either 6 ketamine or 5 midazolam, followed by a single ketamine during 12 days, followed up by a 6-month post-treatment period. The main subject matter being looked at was the change from baseline in the MADRS score at 24 hours after the last infusion. Repeated ketamine showed greater antidepressant efficacy to midazolam after 5 infusions, but fell short of significance when compared to add-on single ketamine to midazolam at the end of 2 weeks. For the introduction, ketamine is a glutamate receptor blocking drug. It is FDA approved for anesthetic use, and it's currently being researched for antidepressant and anti-suicidal effects. 1 dose of ketamine, which is 0.5 milligrams to a kilogram, for 40 minutes has shown improvement in mood in patients with treatment-resistant depression. The peak antidepressant effects occurs at 24 hours post-infusion with gradual loss of therapeutic effects between 5 and 8 days. However, several infusions can prolong the effects of the ketamine. The study conducted a 2-arm randomized active placebo-controlled trial. It was 6 infusions over 12 days, and it compared the efficacy and safety of 6 IV ketamine versus single IV ketamine among patients with treatment-resistant depression. For the materials and methods, it took place at Minneapolis Veteran Affairs Medical Center, April 2015 to March 2019. The subjects were aged 18 to 75 years. It was mostly a white male older population with an average age, I think, being 53. And the subjects met the criteria for major depressive disorder and had a lack of response to at least 2 antidepressant trials of different pharmacological classes during current major depressive episodes. The patients were excluded if they had a lifetime DSM criteria for post-traumatic stress disorder, mild to moderate traumatic brain injury, psychosis-related disorder or bipolar disorder, and any axis 1 disorder other than depression, major depressive disorder as the primary presenting problem. History of alcohol or substance use disorder within 6 months of screening was also ruled out. They were also excluded if they had an imminent risk of suicidal or homicidal ideation or behavior with intent to do so. They were ruled out if their mini mental state examination score was less than 27, and if they had a positive urine toxicology or pregnancy test. Patients received 6 infusions on a Monday, Wednesday, Friday schedule over a 12-day period. 5 midazolam infusions followed by a single ketamine or 6 ketamine treatments were the 2 groups that they were placed into. The fact that the last infusion consisted of ketamine for both arms was kept undisclosed to subjects and raters of antidepressant outcomes at 24 hours. Each infusion of ketamine or midazolam lasted 40 minutes long. Patients fasted for 8 hours before their infusions, and trained raters administered pre-infusion rating scales and repeated them again during a 2-hour post-infusion monitoring period. The guidelines for monitoring vital signs during infusion were as followed: systematic blood pressure greater than 61 or less than 89, and diastolic greater than 110 or less than 40. Heart rate of less than 40 or greater than 130 beats per minute, a respiratory rate of less than 10 or greater than 30 per minute, pulse oximetry of less than 90, and severe hallucinations, confusion, delusions, irrational behavior, or agitation. Study assessments were performed at days 0, 1, 3, 5, 8, 10, and 12 to assess the safety and efficacy of ketamine compared to active placebo during infusion phase. Post-treatment assessments were measured at weekly intervals for the first 4 weeks, at 2-week intervals for the next 8 weeks, and at 4-week intervals for the remaining 12 weeks. The primary outcome was change in depression severity measured by the MADRS score at 24 hours after the last infusion. For the study participants, to break down their process a little bit more, 178 individuals were pre-screened for eligibility through consultation with study physicians. 62 signed consent forms and underwent formal in-person screening. 4 failed the screening. 58 subjects were randomized to treatment, with 4 patients dropping prior to the baseline data collection. And for the people who made it through, the final 54, they were placed into either the 5 midazolam plus 6 single ketamine group, that was 29 of them, and 25 of them were in the 6 ketamine group. The sample was mostly middle-aged, unemployed or retired, married, white males with a history of mood disorder among first-degree relatives. Patients also had a chronic history of depression that included at least 1 past psychiatric hospitalization, with almost half of the patients reporting a previous suicidal attempt. Patients had a current MDE with severe symptoms that failed more than 2 adequate antidepressant trials and augmenting agents. For the results, there was no significant difference between single versus 6 ketamine treatments at the end of the treatment. There was, however, significant change in the MADRS score by groups over time when including all the measures. The mean MADRS score among subjects receiving ketamine was significantly lower by 8.07 prior to infusion, by 8.29 24 hours after infusion 5, and by 6.4 prior to infusion 6, compared to the subjects receiving midazolam. And the chart to the right just shows these statistics I just read off. The MADRS scores at weekly for 4 weeks, biweekly for 8 weeks, and monthly for 3 months were used to determine time to relapse among patients who achieved response after the last infusion. The Kaplan-Meier estimates of the 6-month relapse rates after response was 75% and 68.4% for midazolam plus single ketamine and 6 ketamine group, respectively. The long rank test revealed a non-statistically significant difference between relapse rates over time. The median time to relapse was 2 weeks for the midazolam plus single ketamine group and 6 weeks for the 6 ketamine group. The most common side effects for the ketamine group was general malaise, decreased energy, increased in blood pressure, headaches, fatigue, nausea and vomiting, anxiety, and poor concentration. Most common side effects for the midazolam plus single ketamine group was anxiety, decreased energy, increase in blood pressure, fatigue, and headaches. During infusions 1 to 5, there was a significantly greater dissociation for the ketamine group compared to the midazolam group. All patients receiving the ketamine had complete resolution of dissociative side effects within the 2-hour monitoring period. Participants' dissociative side effects were non-significantly correlated with antidepressant response 24 hours post-infusion for midazolam or ketamine. There was not significant change within or between groups regarding psychotic or elevated mood symptoms at any time throughout the infusions. For the discussion section, they read that there was no significant difference in change of the MADRS scores between groups at 24 hours post last infusion at the end of 12 days of treatment. The repeated ketamine showed greater antidepressant efficacy compared to midazolam after 5 infusions before receiving the single ketamine as the last infusion. The rate of remission and response was greater among subjects in the 6 ketamine group after infusion 4 and 5, respectively. Despite the small sample in this study, this happens to be the largest randomized study that compared repeated ketamine versus an active placebo in treatment-resistant depression. Findings support the idea that repeated ketamine further reduces the severity of depression in treatment-resistant depression patients. However, the antidepressant improvement through 6 ketamine treatments was not significantly different when compared to a single ketamine. For the limitations of this study, the study for the primary outcome was underpowered despite surpassing recruitment goal for a total of 54 participants. A total of 87 patients per group would have been needed to detect the difference of 4 points in the MADRS score between groups at the end of 6 infusions. Ideally, a trial would have included an additional placebo-controlled arm composed exclusively by midazolam infusions. Such a design, however, would have been much more expensive, more problematic to recruit for, and the inclusion of a non-therapeutic intervention as a control may have raised ethical issues. The study allowed concomitant psychiatric medication regimen on stable dosages for at least 6 weeks prior to the study onset. And the study was prominently male and older, leaving us unknown as to how these treatments would affect women, people of color, younger people, etc. And that is all for my presentation. I found this article extremely interesting, and I'm excited to see where ketamine research goes, because obviously, as I said, it's a very newly researched thing for treatment-resistant depression, but it seems to be proving to be pretty helpful for people. So I'm excited to see where this goes. Thank you for watching.